Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about autoimmune hemolytic anemia. When I left off last week, I've gone over all the different signs and symptoms, all the different findings you might discover on physical exam, and all the different tests that has to be done. In this segment, I'm going to start showing you how you treat autoimmune hemolytic anemia. However, before I start, I have to borrow a few minutes from you to go over with you what transpired on May 8th, 2019 at the Glen Harbor Club in New Rochelle, the Mount Vernon Neighborhood Community Health Center Network had their gala, and I was one of the individuals that were honored during that gala. And I'm here to show you the incredible kindness that these people showed toward me by giving me all these different awards and plaques and so on. Over here, this is a plaque from, I believe, from the Mount Vernon mayor's office. Over here is another big certificate from the Westchester County Board of Legislature, and over here in the middle is the actual award that I received from them for that evening. And next to me here, I have the office of the mayor of the city of Yonkers, Mayor Spano, Mike Spano. And over here, I have another certificate from the Congressman Elliot Engel from the U.S. Congress. And over here, I have from the Assemblyman Predlow from New York State Assembly. It was an incredible evening, and I completely enjoyed it. I brought several friends with me. Mark Carter was with me. Dennis was with me. Jim was with me. We had a ball. And you say, well, how did all this come about? Now, if you allow me, when I was in training, finishing my complete training at Montefiore, I had completed my medical training. I was a fellow. I think I had about 3 separate articles that were written. I was co-author of them. But I decided to write an article about the health fair that I had organized when I was a student at Einstein in 1971 at James Monroe High School, during which we collected 2,800 blood pressures, 2,800 pulses, 2,800 temperatures, 2,800 height, 2,800 weight, 2,800 complete blood count, 2,800 complete blood chemistry profile, 2,800 sickle cell tests, 2,800 on and on and on and on. It was an incredible day. No place in the United States prior to that moment there have ever been 2,800 that much data on any minority community anywhere in the history of this country. So I decided to write it up. So prior to finishing my complete training, when I was a fellow in hematology, medical oncology, getting ready to start my practice in 1978, didn't have $1 in my pocket, could barely put gas in the car. I decided to write an article. Now, I had never written anything on my own before. This was the very first article that I've ever written on my own. I decided the best place, I think, on my mind to send this article, being the data collected had to do with minority group individual, were to send it to the National Medical Association Journal. And the editor of the journal was working at Howard University, a Negro gentleman. He passed away, I don't have to mention his name, with a tremendous background, famous, well-respected. And I sent the article there, and the gentleman received my article. I kept talking to him. He even gave me his home number. At least once or twice a month we talk about this article. The material were great. They were excellent. You would name me, all kind words, but he wouldn't publish the article. Nor would he give my article back to me. But kindness, polite, he was a very nice person. We kept talking. This went on for more than a year or so. I decided, you know what? I better rewrite the article a little bit and find somewhere else to put it without saying anything to him. And sure enough, I rewrote it a little bit and sent it to the Journal of the American Hospital Association. Within a few days that I mailed it out, I got a phone call. Oh my God, they were just elated. They were so happy to get their hands on this much material. And within 2 weeks, the article was published. And I have copies of this article deep down in my in my house on the piles of junk that I have there. And then this was the article in which I recommended the construction of community health center to best serve the minority communities throughout the United States. And then the other day, I went on one of the most prestigious places if you want to have your hands on anything having to do with medicine or science in this country is to go to PubMed. And sure enough, I click on PubMed. Here it was. The article was published September 1st, 1978, volume 52, 17, 76.6, 1978. That's PubMed. That's exactly, this is the abstract that I copied from PubMed, in which I explained all that needed to be done in order to bring, and the title of the article was Medical Students, Practitioners Hold Health Fair at High School. That was the title of the article. So this article had a lot. In fact, this is the article that is really was subsequently read into the congressional record that led to the construction of community health center across the United States. As I speak to you, 26 million people are provided care for in community health centers across the country. And on top of that, having done the health fair, this was the first health fair ever done in the United States of America. Throughout the country right now, people are doing health fair. And when health fairs are done, of course, all sorts of abnormalities are detected. And the article clearly explained what I had mentioned, how the best way to bring health care to the, quote, ghetto poor, blah, 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 because they're busy, they're working, most of them working 2 jobs. They'll be able to go there in the evening, they'll be able to go there on Saturday, and also they'll be provided care for by people that are of the same ethnicity as they are. They'll feel more comfortable. I want you to know, a couple of weeks ago, as I mentioned in the show, the AMA published an article that was, I think, on NBC as well, saying that when black people are provided care for by black physicians, the care is better and the outcomes are better. How about that? Okay, so that is why I was honored. It took that many years for finally people to admit the fact that I've done. That's one of the things that I had done. Okay, so in any event, I wanted to, again, once more, thank Miss Judith Watson, who is the Chief Executive Officer at the Mount Vernon Neighborhood Community Health Center Network, for really putting my name forward to have this stuff done. And finally, I lived long enough to finally get recognized, as I have done many other things that folks all over the country are killing each other to try to get credit for. Some of them are hoping, waiting for me to die so they can get credit for it, such as male circumcision to prevent the spread of HIV/AIDS. As we speak, 70 million men across the world have been circumcised, according to WHO. I published that in August of 1986 in the New York State Journal of Medicine. Okay, the whole concept of hypertension. What is hypertension? Where did it come from? It was a gene. I came up with the idea. The gene was discovered. I can go on and on. In fact, some of my colleagues and friends are pushing me to write a book about all the stuff that I was the first to come up with the idea with. Now you see how I wind up becoming an M.A.C.P, even though I'm a little community here in White Plains practicing medicine, and yet I got this big award, the big prestigious M.A.C.P, because of all this stuff that I had done. It's a college, now that I'm part of, we don't just recognize people for scientific discovery. We do that too, but you also must tell us what it is that you're doing to help people on a daily basis. And this is how I wind up becoming an M.A.C.P. I had written 8 books, and my resume was 19 pages. Now I've written 28 books, and my resume is 33 pages. How about that? Okay, and right here in the community, I'm the only physician, as far as I know, with my credential that's practicing medicine in the community and helping poor Negro folks, working poor Negro folks. I'm the only one in the country. I'm not the only black person, but the only one that's doing it in the community. All M.A.C.Ps are big shot with multi-million grants, blah, 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 blah. Me, I've been offered all kind of job. I say, no, I don't want anybody's job. Let me stay right here to do my thing. I fight my battle. I always win, by the way. I keep fighting it here. In any event, as far as getting back to, I wanted to share this with you because this is not something that's happened very often. So please forgive me for taking your time to share these things with you. So in any event, now getting back to autoimmune hemolytic anemia, how do you know it's a hemolytic anemia? Well, very simple. Patient comes in anemic, then you want to find out what type of anemia it is. Well, the most important thing, that test that you must do, and keep that in mind, put it in the back pocket, is the reticulocyte count. How come? Well, there are 3 types, there are 3 things that can have, 4 things that can cause anemia. The basis of it. Either you are not making enough red blood cell, you're making enough red blood cell, but you're bleeding them out, or you're hemolyzing them. But the reticulocyte can tell you 2 things. Either hyperproliferative, first of all, it's normal proliferative, meaning the reticulocyte is normal and yet you're anemic. Hypoproliferative means that you're not making enough red cell. Or hyperproliferative means that the reticulocyte count is high. It's high because you are hemolyzing. That right away, you concentrate on that. Okay, you may have a combination of the 2, that's the 4th possibility, but you don't have to go all over the place spending thousands of dollars or doing all kinds of silly tests. You already know you are hemolyzing. How do you know? Because when you are hemolyzing, the body is dumping a lot of young red blood cell into the circulation. Those are reticulocytes. Because the body is trying to make up new red cell, can't get time to finish it, so they're dumping it into the circulation. And to do the test is simple. Simple. All you have to do is to go into the laboratory, take a little bit of blood, a drop of blood, put it in the slide, smear it, let it dry, and then you put gram Ginseng on it, and then you're going to put it under the microscope. When you put it in the microscope, you're going to see early red blood cells that have a lot of RNA inside them. That they're going to be bluish stuff inside them. Why is that? Because what happens is that the red blood cell they stop growing. There's a delay in maturation. Because there's a delay in maturation, you have RNA. When the whole process is finished, the RNA is gone, the RNA did the thing, it's finished. But when you have a delay in maturation, you have the red blood cell is big and is bluish in the center. That's RNA. Because of delay maturation, it can't go to the finish to become mature red blood cell. And you pick that up by staining the blood with gram Ginseng. Very simple. And all you have to do, put it on the microscope, and you count 100 cells. You have the smear, and you count that, and then the number of reticulocyte count that comes out in 100 cells. That's your percentage of reticulocyte count. There is no fancy computer. You have to do it manually, and you have to learn as a medical technologist, and they learn that how to do that. You put it under the microscope. You're looking at it. You're actually looking at and you're counting. You have a counting thing, how many red blood cells and how many immature red blood cells was in between it. That's all. And then it's a percentage. Okay? So when you are hemolyzing, regardless of the source of the hemolysis, you're going to have a lot of reticulocyte count. It is hyperproliferative. And then all you have to do then is go ahead and find what type of hemolytic anemia it is. You're doing hemoglobin electrophoresis to rule out sickle cell disease, to rule out all the thalassemias, to rule out alpha thalassemia, to rule out hemoglobin poor, to rule out hemoglobin C, on and on and on. You do it quantitative. You can't miss it. It's simple. All you have to do is order a quantitative hemoglobin electrophoresis, not qualitative, quantitative. It's going to come back, give you the percentage. If it's all normal, and this is still going on, that's alpha thalassemia by definition. How about that, okay? And then you do that. That didn't help you. That's fine. You go back. Then you do an ANA. You do a sedate. Why are you doing an ANA? You're doing the ANA because the ANA is likely to be positive when you have other autoimmune diseases that may be associated with the hemolytic anemia process. If that doesn't exist, then you go forward, you go do a direct home test. How about that? The direct home test is done very quickly, very fast in the blood bank. Bango is positive. You just diagnose autoimmune hemolytic anemia as opposed to autoimmune hemolytic anemia. That may be to a whole lot of other stuff. Thousands of other stuff can cause hemolytic anemia. We're talking about autoimmune hemolytic anemia. And then when you do get the direct home test positive, then you go about treating the patient. You keep looking. Don't stop, because there are many other diseases that you could pick up at the same path, the same day. It could be a thyroid problem. It could be Hashimoto's, right? Okay. And it could be rheumatoid arthritis. It could be lupus. It could be scleroderma. God knows what it's going to be, but you have to keep looking. And the thing that tells you that your set rate will be very high, your ANA will be positive, and so on, that's when you have what's called overlap syndrome, meaning that you have hemolytic anemia in association with other problems. It is your job to find out what that other problem is by knowing what tests to do. You do an LDH. You cannot have autoimmune hemolytic anemia or any hemolytic anemia without having an elevated LDH. But the LDH can be elevated in a whole lot of other stuff. The LDH may be elevated because the liver is bad. The LDH may be elevated because you have lymphoma, you have leukemia, because all hematological malignancies will cause your LDH to become elevated. You say, well, how come? Well, because all these cancer cells are growing without oxygen. Okay? Because they're growing without oxygen, the end product of that pathway is lactic dehydrogenase. So when you have elevated LDH, you must look. That may be your first key. You're dealing with a malignancy. Because all these cells, they grow in an anaerobic way. And the end product of the anaerobic pathway is lactic dehydrogenase. My goodness, it is not that difficult. You simply have to know. You do it, and then you monitor the LDH as you are treating the patient. You monitor the reticulocyte as you are treating the patient. As the patient improves, the reticulocyte goes down, and then what's the problem? As I mentioned last week, you have an autoimmune disease. The body develop an antibody. And the body is fighting against it. You have an antibody-antigen complex. Those complexes piled up on the top of the red blood cell. And as soon as that happens, the body is reading the red blood cell as a foreign. So your red blood cell now become a foreign material. And the spleen, the main job of the spleen and the setting was take them out. Destroy them. Grab the red cell, grab them and take them out. Just take them out. And then all reticular endothelial cell, all monoclonal cell in the body are also going to take them out. How about that? So therefore, this is basic clinical medicine, physiology stuff that you must know. That thing doesn't leave you. You learn it in medical school, it stays with you. You have to understand it. You have to put it into practice. So now that you've done that, the next step is what? You're going to try to treat. First, you look for the cause, because like I say, the causes could be many. But you also have to treat the patient. because the patient is hemolyzing. Dumping blood transfusion into the patient may not do the job because that's just putting gasoline into fire. You're going to cause the patient to hemolyze even more. Furthermore, when the patient is hemolyzing, he or she is dumping tons of iron into the blood, into the bloodstream. Because the red blood cell must release the content. And part of the content is iron. And iron is very necessary for the body, but also very toxic to the body. So the more blood transfusion you give, the more iron you're dumping in the body, because each unit of blood has 250 milligrams of iron. You may not want to do that. You will only do that if the patient is elderly and or is having chest pain. You think the patient is about to have a heart attack. You need, because of lack of perfusion with oxygen of the heart, you may want to transfuse the patient acutely, but there are ways of doing it. First, you got to take your time. First, you have to understand what you're doing. Take your time, go to the blood bank. Say, I have this patient who is having chest pain. He or she is in the CCU or whatever, needs some blood because he or she is about to have a heart attack because of lack of oxygen. Where the lack of oxygen comes from? It's not just because the total volume of the red blood cell is low. Yes, but there's something else going on. What is that something else? Well, when you become that anemic, the oxygen dissociation curve is shifted to the left. Once it is shifted to the left, the little bit of oxygen that the hemoglobins are carrying will not let go. They're holding on to it in a false attempt to save the body, but it's not working because they won't let go of it. So what's the use? To make them let go of it, you have to do something to shift the oxygen dissociation curve to the right. Only when that curve is shifted to the right can the red blood cell release the oxygen that it is carrying. Do you understand that? So therefore, if you go to the blood bank, or you don't go to the blood bank, you just write a prescription to transfuse, you might hurt the patient more than help. Because the blood bank job, and I used to be a blood bank medical technologist, is to get rid of the oldest unit of blood in order not to throw it away. So the blood bank is more than happy. Somebody just ordered blood. They open the refrigerator. They look at the date. They're going to give the patient the oldest blood that is type specific to get rid of it, because otherwise it's going to get spoiled. When it is spoiled, they're going to throw it away. However, when the blood is sitting there, you have to remember something. Medicine, my friend, and I don't mean to be too petty, but I mean to be factual. You either know it or you don't know it. When the blood is sitting there in the blood bank, several things happen. ATP, which is adenosine triphosphate, is crucial. It's decaying. 2,3-GPG is decaying. So therefore, the blood that you're going to give to the patient may be deficient in ATP. It may be deficient in 2,3-DPG. So therefore, you're going to harm the patient more than you're going to hurt the patient, because the blood you're presenting cannot do anything for the patient, because it's not going to carry oxygen properly. So what you do, then you go to the blood bank, speak to the blood bank supervisor, tell he or she, I need a fresh unit of blood, a blood that is about a week to 2 weeks old, and explain the concept. Believe me, he or she will understand and will comply to give you the freshest blood. As soon as you transfuse that blood in the patient, it's fresh blood. It is loaded with ATP, loaded with 2,3-APG. That automatically going to shift the oxygen dissociation to the right. That's right, because it is good blood. It is rich with ATP and 2,3-DPG. Those are crucial to keep the oxygen dissociation curve to the right. And then therefore you're now really helping your patient, because the patient is getting good blood that's going to shift the curve to the right, and the patient now is going to be able to release, the hemoglobin will release the oxygen to help the heart, to help the brain, the kidney, whatever it is you're trying to help. I understand that these are difficult concepts, but don't expect me to sit here and apologize. It took 40 plus years to learn this stuff. You want to learn it? Yes, I'll teach you. You don't want to, that's your problem. You stay there where you are. Be a big shot. But if you're going to be a big shot, you're going to be arrogant, you might as well also be smart. And be arrogance is a bad thing. Yes, it's a bad trait. But if you're going to be arrogant, you better damn well be smart as well, intelligent. If you're not brilliant, shut your mouth, okay? Because you're going to hurt people. You don't know what you're talking about, keep your mouth shut. So therefore, then, you're going to help this patient. So you're going to transfuse the patient. You rather not, but if you have to, that's how you go about it. The next thing you're going to do then, what you're going to do to treat the patient? Well, in the old days, we had a whole lot of problem treating patients, a whole lot of problem, because we really had difficulty finding stuff to give to people to treat them, because we didn't have a lot of good stuff. Steroid was the main medication, intravenous steroid to treat someone who have autoimmune hemolytic anemia. You must give them folic acid. And the steroid dislodges the antigen antibody complex that's sitting on the red cell, allowing the red blood cell to grow properly. Then you could give intravenous immunoglobulin. We used to do that. They're still being done all over the world. You have to understand the folic acid cannot be just 1 milligram. 1 milligram of folic acid is only good for nutritional purposes. The recommended dose, the highest dose recommended is 25 milligram. Okay? So you have to understand that, because when you are hemolyzing, you're losing folic acid. So you need more folic acid. However, the best medication available in 2019 to treat autoimmune hemolytic anemia happened to be Rituxan. Okay, it is Rituxan. It's the best. It's a monoclonal antibody. Monoclonal antibody is Rituxan. Is the best medication to treat several dozen diseases, among them because the D20 lymphocyte is going to be pushed aside by the monoclonal antibody, which is Rituxan, allowing you to stop the patient from hemolyzing. So the best medication, 755 milligram of Rituxan, and you give that weekly for about 3-4 weeks, the hemolysis will stop, and it's expensive. In the old days, they used to take the spleen out. Now you don't have to do that anymore. Remember, Rituxan is a medication that is used to treat autoimmune hemolytic anemia in 2019. Okay, that's high-powered, high-class academic clinical medicine. That's the medication, okay? Listen, I want to stop here until I see you again. This is Dr. Alcena saying so long and bye-bye.